Well, so good afternoon, everyone. I'd like to thank PHEN and the moderators for having me speak today. I'm going to talk about erectile dysfunction. It's something probably about 30% of my practice currently is erectile dysfunction management. We're going to talk about erectile dysfunction management as a whole, and then we're going to finish up with some special considerations as it pertains to prostate cancer patients. So as we just said, I am an associate professor here at Howard in DC. And I work closely with our cancer center and some of the other folks to try and provide services related to what's called cancer survivorship, which is trying not to allow treatment for prostate cancer to take away the joy that you can still have in life after the diagnosis. So I have no relevant financial disclosures. I don't get paid for this talk or anything that I'm going to be speaking about today. So erectile dysfunction in general is very common, and it's defined as the inability to get or keep an erection firm enough for intercourse. So this is something that is really diagnosed by the patient. The patient comes in and says, "Doc, I have this problem." It doesn't mean that you can't get erections. It just means that they are not what you want or what you expect or what you need to be able to have intercourse. It's relatively uncommon in young men. So under age 40, we only see about 5 to 7% of men that have erection problems. But by age 50, depending on the studies you look at, it can be anywhere from 15 to 50% of people. And certainly we know that it is a disease of aging. As you get older, the erection quality basically deteriorates. One thing that we sort of forget about is erections are a reproductive mechanism. And so much like in females where the reproductive organs weren't necessarily designed to last for 100 years, we have a similar unfortunate problem with erections. So this is sort of a nice chart that I like to show people because a lot of times people say, "Well, Doc, why do I have this problem?" And the answer simply is it's usually multifactorial. So a lot of times you will have underlying diseases, you may have medications, you may have certain choices in life that you've made. And then all of this, as we just heard, overlaps some with the psychologic factors involved with erectile dysfunction. So I would say in general, most commonly the conditions we see that lead to erectile dysfunction aside from advanced age would be diabetes, high blood pressure, smoking, which is certainly the #1 preventable cause of erectile dysfunction. Medications, there are 200 plus commonly prescribed medications that can decrease your erections, and there are certainly over-the-counter medications as well. And then pelvic malignancies, as is the case that we're sort of focusing on here today. So some important side notes to the treatment of erectile dysfunction in general. Men will ignore a lot of symptoms. So guys will avoid going to the doctor for a lot of reasons. But one thing they try not to ignore is their penis. So as a urologist, this is one of the few times when I can intervene and actually help direct them in a way that improves their overall health and life expectancy. Because what a lot of people don't understand is that erectile dysfunction is a sign in many cases of underlying vascular disease, and the two share in a lot of ways common etiologies. So if you take patients with the conditions we talked about on the last slide, particularly smoking, uncontrolled blood pressure, or diabetes, and you add to that a diagnosis of erectile dysfunction, that drastically increases their risk of cardiovascular disease. We know that on average, there's about a 3 to 5 year gap between the development of erectile dysfunction and the development of symptomatic cardiovascular disease. And if you take patients, again, with those underlying risk factors, and you add erectile dysfunction to that, those patients have about a 7-fold increase in cardiovascular disease risk. So your penis in a lot of ways can be like a canary in the coal mine. It's telling you that something's going on that's not going to end well. And if you don't pay attention to it, there's going to be a problem. But if you do pay attention to it, you may be able to sort of right the course and make things better. So I think that's important when talking to men in general about erectile dysfunction. The other thing, as we just heard about, so I won't go into too far, is that I think men tend to underestimate the psychology of erectile dysfunction. Men place a lot of importance on their sexual prowess, their ability to get erections, and how that ties into our self-esteem. And so regardless of what we can do to help you get erections, if we don't address the underlying psychosexual dysfunction, anxiety, depression, those issues, it's going to be very hard to get you back to a healthy sex life. So I'm going to talk about the treatments for erectile dysfunction as a whole, because in general, we have a finite number of treatments for erectile dysfunction, whether it's caused by what we just talked about or whether it's caused by prostate cancer and prostate cancer treatments. So I usually sort of put things in little bundles so it's easier for patients to compartmentalize. There are basically three versions of medical therapy. There's oral medications, there's urethral suppositories, and there's injectable medications. And we're going to talk about more of these separately. Then there's procedural or sort of non-medical therapies such as vacuum devices and penile implants. And then a lot of patients will come in and they've heard about this on the radio or the newspaper, and they say, well, I don't want to have to do something every time I want to have sex. I don't want to have to take a pill or use a device. Can't you just make my erections the way they used to be? And so there are so-called restorative therapies that many of you may have heard of. And those are things that I sort of say are in the pipeline. They're not something that are really prime time yet. And we'll talk about that again in a minute, but it is because of advertising, this is a big market. And I know here in the Washington, DC area, there's at least 3 or 4 clinics that advertise these therapies. So patients will often come in and ask about them. All right, so sort of one of the newest therapies, which probably most people are very familiar with, is oral medication. Pre-existing the oral medication, we already had sort of cruder versions of prosthetics. We already had injectable medications. And sildenafil came on the market around 1997 in the United States. It was the first commercially available, what's called phosphodiesterase type 5 inhibitor. It's an interesting backstory. It was actually discovered on accident. They didn't know it was going to help erections, and they were studying it for something else. And they found that it wasn't working, so they asked for the medication back, and the study participants didn't want to give the medication back. So when they looked farther into that, they found out these guys who had erectile dysfunction were suddenly getting really good erections, and that's how we discovered this medication. So the way this medication works is it promotes this chemical messenger called nitric oxide. So you have blood vessels that feed blood into the penis to get an erection, and those blood vessels by and large are controlled by the nerves, and the nerves give the signal to the blood vessels through this intermediary called nitric oxide. Nitric oxide is broken down very quickly, and these medications prevent it from breaking down. So you have a larger amount of nitric oxide, a larger amount of that chemical messenger, the mediator in the system. So obviously, since 1997, there have been 3 other oral medications, tadalafil, vardenafil, and evanafil, that have come out. This is the sort of chemical names. They all have trade names, but to try and avoid, bias, I haven't listed those here. And it's important to understand how these work because they all are in the same family, but they are a little bit different. For example, sildenafil does not absorb as well with food, so it's better on an empty stomach. The others are a little bit better if you're going to take them with food. Tadalafil has a daily use indication, which may be helpful for patients in terms of spontaneity or what we're going to talk about later, recovery from prostate cancer therapy. And then, for example, evanafil is very spontaneous because it works in about 15 minutes. So these are important things to talk with for each patient because while the medications by and large work similarly, there's not just a one-size-fits-all approach for everybody. And certainly everyone has sort of different structure to their sex lives in terms of spontaneity, interest of their partner, and then cost of these medications, thankfully, recently has come down quite a bit to where you can get them in most situations for around $1 a pill. So suppositories, there is a branded suppository on the market, which is a type of prostaglandin. It sort of looks like a little piece of rice that comes in this plastic dispenser. And so generally this dispenser goes in the urethra in the hole in the tip of the penis, and then you're able to inject the little pellet into the urethra. Now, prostaglandin works by directly stimulating the blood vessels, so it does not need the nerve input. And so in some ways that may be useful in prostate cancer patients as well. The downside of this is it can cause some discomfort. And if you ejaculate after putting it in before it's fully dissolved, it can cause some discomfort in your partner as well. And then we have injectable medications. You see here listed, there are currently 4 that are being used. And these are injected not into a vein, but into what's called the corporal space. So you see here where the needle is injecting sort of in the side of the penis, there are 2 corporal spaces within the penis. And if you look at them, they kind of look like a kitchen sponge. They have lots of little holes. That's where the blood fills up with an erection. So this medication goes directly to the source to stimulate the blood flow and cause an erection. This can be done without any sexual stimulation, and even in patients who've had prostate removal that required removal of the nerves. This is sort of your typical vacuum erection device. It's a plastic tube that you can put inside, you put your penis inside. It uses vacuum pressure to pull blood into the penis. They have a regulator so that you can't apply too much pressure and cause damage to the skin or other portions of the penis. And then you see at the bottom there are those different size little rubber rings. Those are able to be applied to the base of the penis sort of as a tourniquet. And that allows you to release the suction and be able to take the device off and use this for intercourse. We'll also talk about later, there are some ways to use this for rehabilitation. So these are examples of penile prostheses. You see on the left is what's called a malleable device. This is a device that just bends. It does not actually change size or shape. The middle device and the device on the right are two different versions of inflatable prosthetics. I put both of these here because they're two different manufacturers. So this is what the two different manufacturers' devices look like. But as you see at the bottom, we remove that spongy tissue that we talked about in the previous slide. We put these inflatable cylinders, one on each side of the penis, and we put a pump down in the scrotum inside the sac, kind of like a third testicle. And you're able to squeeze that pump to transfer fluid from a reservoir, which we place inside the abdomen, into the penis and back to allow you to get rigidity of your penis for sexual activity. A lot of people ask, does this affect sensation? And the answer is no, because the nerves that we feel sexual pleasure with are sort of outside the area where this pump is put in, so sensation is preserved. And then as far as the restorative therapies, the two that are most commonly advertised, as I said, certainly in our area, I hear them on the radio and they're in the sports section all the time, is a so-called P-shot, which is platelet-rich plasma injection. So what they do with that is they take some blood out of the patient, they spin it down to get all the platelets and basically re-inject them into the penis. There's also low intensity shockwave therapy where they actually apply sort of focused sound waves to the penis itself. And the goal of both of these therapies is to trigger a natural sort of innate healing sensation to grow new healthy blood vessels or to restore the health of the smooth muscle, the muscle that's within that spongy tissue we talked about. So the official sort of position statement on these therapies is that there is evidence to support their use. They may be beneficial, but that the evidence is not to the point yet where we really can recommend it to patients or offer it outside of trial type therapies. And you'll find that the centers that do offer these are charging cash, and it generally is not an insignificant amount of money. And so currently, these are not offered in most urology offices unless you're at a center that has a clinical trial looking at the efficacy. And I tell patients, you know, we don't know exactly how these will sort out. They'll probably have benefits for certain subsets of patients, but they're not ready for prime time yet. They're still kind of in the pipeline. All right, so I want to switch to prostate cancer specific sort of topics here. This is just a generalized schematic of what happens when you have prostate removal. But I wanted to focus a little bit more on a couple of these pictures. The one that you see in the middle, this is just general anatomy. So many of you may be aware of this, but for those who aren't familiar or maybe have new diagnoses, your prostate is this small gland that you see that lives under your bladder. The prostate is part of the reproductive system, and it's the Y connector. So that's why men have one hole for sexual and urinary function, whereas women have two. All of our urinary and sexual systems come together in the prostate. And you can see the prostate sits under the bladder. It surrounds the tube that we pee through, and it sits right on top of the muscle that controls urination, which we're going to hear about in the next talk. Specifically to erectile function, I wanted to focus on the sort of bottom left picture so that people understand the anatomy of the nerve innervation. And for people who talk to surgeons or who have had surgery, you'll oftentimes hear the term nerve sparing. And so I wanted to make sure everyone's familiar with that. The nerves that control the penis come out of the sacral spinal cord, which is the part of the spinal cord at the very bottom near the tailbone. They wrap around the rectum, and on their way to the penis, they are very closely adherent to the capsule of the prostate. They sort of are, you know, stuck to the capsule of the prostate, sort of like if you had an orange with a wet newspaper draped around it. And so damage to those nerves will affect the ability of the nerves to transmit nitric oxide to the penis, like we discussed before. Even in cases where the nerves are spared, the nerves have to be peeled off the prostate, which can cause some temporary dysfunction to the nerves from stretch injury. And so that's why the penis is affected by prostate cancer surgery, and why the surgeons try and spare the nerves on both sides if possible, one side if not. And in some cases, they're not able to spare the nerves because the goal of the surgery is ultimately to get rid of the cancer. And so in some cases, the nerves do have to be spared in order to accomplish that goal. But I wanted to make sure everybody was clear on that and why this is such a big topic and such a common side effect of prostate cancer treatment. A couple of other things I think people should understand is that when you have surgery, which is most commonly radical prostatectomy, with most of the time in this country done with the robot, or potentially cryotherapy, which is where they freeze portions of the prostate, the effects are going to be immediate. So damage to the nerves, whether it's stretch injury, whether it's transection, temporary or permanent damage, is going to be seen pretty much right away. And then there's going to be a period in which we can expect some recovery. So it's relatively uncommon for men after prostatectomy to get erections within the first 6 months. In a lot of cases, we do have men who do get erections, but that's more rare. For patients who opt for radiotherapy, they're going to see a much more delayed process. So it's not uncommon. We hear a patient who says, I just got done with my radiation treatments, everything went great, things are working well. But unfortunately, you're not yet out of the woods when it comes to these problems, because we can see anywhere from 1 to 5 years delayed effects of radiation that people can still suffer with. So it's important to understand that and to set your expectations accordingly. So some considerations, particularly for people who maybe have new diagnoses or are pondering what to do. Not everybody enters prostate cancer with the same degree of erectile function. So we have a sort of common questionnaire many of you may be familiar with called the Sexual Health Inventory Questionnaire. Basically, the patient answers 5 questions, and based on the score, we're able to see what kind of baseline erectile function they have, understanding that no treatment for prostate cancer is going to improve your sexual function. But if you start with poor sexual function, that's important to understand, again, to set your expectations accordingly. Penile rehabilitation is something that we'll talk about because that's part of the idea of cancer survivorship. It's important to understand that, particularly for surgery, not everything always goes as planned. And there are times when the surgeon may have talked about bilateral nerve sparing, but they were only able to spare one side, et cetera. So it's important, again, after the procedure to be able to adjust our expectations. And then, as we heard about before, when we're talking about telling patients, well, it may be 1 or 2 years after your surgery before we know what's going to happen in terms of your recovery, that's a long time, particularly when they're getting PSAs back within 6 weeks and 3 months, and they're reassuring them that their cancer is gone. And so I won't go too far into this, but for a lot of patients, I do recommend that they see a dedicated sex therapist or a couples counselor, because this is a difficult time to get through psychologically for patients and their significant others. So lastly, we'll just go through this idea of penile rehabilitation. And this is something that has sort of entered the mindset of medicine probably within the last 20 years or so, particularly as we talk about the idea of cancer survivorship. Historically, if you had cancer, a lot of times you'd say, well, we're sorry, we have to burn it out or cut it out or give you chemotherapy, and whatever you're left with, you should be happy to be alive. Well, we've started sort of taking a step back and saying, yes, we have to do things to keep you alive, but we also have to do things to not let the cancer treatment rob you of your quality of life, because whatever days you have left on earth, we want to be, as happy and fulfilling as possible. And so the idea of penile rehabilitation is the idea of using a device or a medication to enhance the recovery of erectile function. And you can see the ones studied here are the oral medicines, the vacuum device, and the injections. This idea makes sense because we have a lot of good data, both from animal studies and also human studies, that this tissue that I talked about before, this spongy tissue that fills the corporal bodies, is a type of vascular tissue. And if you disrupt the nerve input, whether it's stretching or transection or any sort of injury to the nerves, you're going to lose erections. And that may be temporary or permanent. Now, predominantly, we're talking about nocturnal erections because that's the bulk of erections that men have. You get one about every 90 minutes while you sleep. And that new influx of blood and healthy factors that are within the blood is what keeps this tissue healthy. So with loss of erection, you stop having inflow of that blood, and basically the smooth muscle, the tissue in the penis that was healthy becomes unhealthy, and your body replaces it with collagen, elastin, and other tissues that are not stretchy and allow for poor erectile function and also shortening of the penis, which is something a lot of people experience after prostate cancer therapy. So this can be started prior to or immediately after treatment, depending on the therapy you're talking about. And I think most people support the idea of penile rehabilitation. The issue, and what I put here, first, I think on this slide, I had said that it was controversial. I don't think that's the right term. I think most people support it, but you have to look at what you're trying to accomplish. So for example, with the oral medications, we know that people who are on oral medications, even starting before their surgery and immediately after their surgery, will return to having an erectile dysfunction quicker than those who are not on medications. However, that's a bit of an artificial response, because if you take the medicines away and you allow a washout period, that certain percentage of patients, their erections will go away again. So it's probably not really helping the tissue heal per se, but it is artificially restoring blood flow sooner, and there is some thought that that's helpful overall. Vacuum device, again, can be used to pull blood into the penis. It can also be used to stretch that tissue that we talked about before. And there's even data that starting vacuum therapy as far as 6 months after surgery can still help with recovering length that's lost through therapy. And then the injections, again, these are going to work directly regardless of your nerve status to bring blood to the penis, and they work very well. But in general, injections are not well tolerated by patients. They don't like the idea of needles. You have to keep them refrigerated. They cost a certain amount of medicine. And the drop-off rate for injections is pretty high. It's about 70% at 2 years for most patients. And so while there is some evidence that this does help with recovery of erections, it's a tough sell in a lot of cases. So with that, I think my time is up, and I will welcome any questions. Thank you for your attention.
Okay, thank you, Dr. Tonkin. Great presentation. A couple of things. One with the medication. One of the frustrations that I have, the medication, oral injection or whatever, or suppositories in 2004 was not covered by insurance. And I can remember paying up to $14 to $15 a pill. Luckily, as a disabled vet, I now get medications at no cost. Has that changed on the market?
It has, yeah. So I commonly now use a compounded version of these medications. And it's locally here, we use a mail order pharmacy. Patients are getting these pills outside or regardless of their insurance status for around $1 or a pill, or less than $1 a pill if they're buying in bulk.
Okay.
So the cost has gotten significantly more palatable, even for patients uninsured or insurance that doesn't cover the medicines.
Okay, thank you. Another one you mentioned was injection. There's an injection now, EDEX, EDEX, where it's you mix it right before you use it. It's mixed in the syringe, so you don't have to keep it refrigerated. Very convenient, very easy to use. You can get closer to that spontaneity, and the pain is minimal.
Yeah, EDEX is prostaglandin, which is one of the drugs I mentioned. It is a little more user-friendly in terms of the powdered situation. Again, we go back to what you mentioned, cost. I know for military, for veterans and things like that, EDEX is covered through the VA system and some of the other support systems they have for veterans. But for patients with civilian insurance or patients with insurance that doesn't cover it, EDEX is 5 to 20 times the cost of prostaglandin from a compounding pharmacy. So sometimes with the financial issues, we have to sacrifice convenience for finance or vice versa.
All right, thank you. We had one question from a participant. Are there medications that work with hypertension medications?
Yeah, so hypertension medications are probably some of the most common medicines that decrease erectile function in general, particularly beta blockers, hydrochlorothiazide. So those are the big ones. None of those medications are contraindications to any of the things that I just talked about in terms of treatment. Really, the only medication that is a contraindication, particularly for the oral, the PDE5 inhibitors, is nitroglycerin or nitroglycerin containing blood pressure medicine such as isosorbide.
Okay, we have time for one more question. What is the success rate of men who have had inflatable penile implants and artificial sphincter surgery? my penile implant was removed due to complications.
Yes.
And I had,
So when you say success rate, I would have to challenge you in terms of what you define as success. If you look at penile implants, the satisfaction rate of patients and their partners when surveyed is upwards of 90%. Now, the complication rate in terms of infection when you place the device is around 1 to 2%. And the mechanical breakage rate is quoted commonly at about 50% after 10 years. So about a 50% half-life in these devices. So again, it depends on how you're discussing success. Similarly, and I'm sure that we'll cover this in the next talk, but artificial sphincters are about 90+% successful in terms of getting patients dry, but also have a mechanical failure rate and an infection rate similar to what I just discussed.
okay, thank you. Mr. Ferriton, do you have any additional questions?
There's one question here. What does insulin have to do with anything?
Well, I don't know. I think my answer would be that in general, patients that have insulin dependent diabetes have a little more brittle diabetes or diabetes that's harder to control. And so diabetes, as I said, it tends to be one of the major causes of erectile dysfunction. But I would say on the flip side of that, that insulin dependent patients are generally a little more comfortable around needles. And so the idea of doing intracavernosal injection is a little bit easier sell than it is for patients who have not conquered needle phobia.
Thank you. There's one other question here. Are there medications that work with hypertension medications?
Yeah, I think we just talked about that,
Right.
aside from isosorbide, you can use
Gotcha.
the medicines with all the other hypertensive medicines.